Welcome, Rachel. Thank you so much for being here and for coming.
You.
Uh, I'm going to go ahead and just let you go. But I will really quick introduce you again, this is Rachel Byers. She's here from the Utah State University Institute for Disability Research, Policy, and Practice. And she is part of their mental health and customized employment teams. So this really does just go right into what we were just talking about. I'm excited. Thank you so much, Rachel.
Okay, thank you so much. My goal is to be useful to you all, to be able to answer questions, and hopefully you can walk away with something that you feel is actionable. And what I want to do today is talking about the mental health needs of individuals with intellectual and developmental disabilities. The introduction explained I work at the Institute for Disability Research, Policy, and Practice. I'm a project coordinator there. I am specifically a member of our mental health team, and I have two projects right now that are directly related to mental health. We have a training initiative for mental health and intellectual and developmental disabilities specifically. And then I also have a participatory project where we have members of the community who are elevated to co-researchers. And that's a qualitative project exploring the experiences of adults in Cache Valley specifically who have co-occurring mental health concerns and intellectual and developmental disability in accessing services. So that's a little bit about what we have going on right now as far as mental health projects are concerned. This is definitely an important topic. A lot of discussion is happening, a lot of research as well. So I'll provide as much insight as I can today. As I mentioned, I'm a project coordinator. I'm also the principal investigator on our MHIDD training initiative. I have a background in public health, so I have a very specific interest in health outcomes for people with disabilities, specifically mental health. I'm a self-advocate when it comes to mental health treatment access and outcomes. And I also have a passion for education for providers and professionals. And this is a quick plug. Last year, we reached our official 50th year of the Institute for Disability Research, Policy, and Practice, which was formerly the Center for Persons with Disabilities. So if you're more familiar with that, we did have a name change recently to a much longer title that's harder to say. Today, I'm hoping in the time that we have, again, I apologize for being late. I'll adjust a little bit for that, but I'll make my slides available for sure. And I'll be available to answer questions afterwards. I'll provide my email so you can reach out to me that way also. My goal is to help you understand the nature and extent of mental health disparities and issues among individuals with intellectual and developmental disabilities. Discuss some of the potential issues that we run into when we're trying to diagnose mental health concerns and how that applies to individuals with intellectual and developmental disabilities, and identify some emerging or promising treatment or coordination considerations when we're working with the co-occurring population. And then finally, identify some resources and trainings for parents and individuals who might benefit from this.
And Rachel, we don't have a session after this, so I might just give a little shout out at 8:25 and award a quick prize, but then we can keep going. So don't worry about it.
Okay, sounds good. And some of this information that I provide, many of you may be familiar with this. It depends a lot on your background, your connections with people, and your experience. But as a quick review of the definition of a developmental disability, from the NIH, we're talking about severe long-term disability that can affect cognitive ability, physical functioning, or both. And it's important that we pay attention to these official definitions because it drives our service provision. That determines who is eligible for services in a lot of cases. So we like to bring up those official definitions because they do influence the services that are available a lot of the time. Thinking about developmental disability as an umbrella, you can say that all intellectual disability could be considered a developmental disability, but not every developmental disability is an intellectual disability. In some cases, developmental disability may include physical and intellectual components. In other cases, it does not. And there are a few examples of developmental disability that I've listed down here. And I will note that there's a lot of discussion in self-advocate communities about how we define disability and whether or not autism is considered a disability, and thinking about the social construction of disability that surrounds this all. So I will note there's a lot of discussion about how we define disability, especially among self-advocate communities. So I do have autism as an example on here, just with that note about the community. ADHD, or attention deficit hyperactivity disorder, cerebral palsy, Down syndrome, visual impairment or blindness, hearing impairment or deafness. Traumatic brain injury before the age of 21 is considered a developmental disability because it happens during that developmental period and will likely affect their developmental trajectory. And mental health concerns. Mental illnesses are health conditions involving changes in emotion, thinking, or behavior, or a combination of these. They can be associated with distress and or problems functioning in social, work, or family activities. That's the APA's official definition from 2022. It's not related to IQ. Officially, it's not related to intelligence or intellectual disability. The general population incidence is about 16 to 20%. So if you're in a room with a random assortment of people, it's about 1 in 5 individuals that experience some sort of mental health concern. Something to note, and members of the disability community are very aware of this. Sometimes I interact with individuals who aren't aware that individuals with intellectual and developmental disabilities experience the full range of mental health concerns, just like the average, quote, population. The catch being that they are widely undiagnosed, misdiagnosed, and mistreated. One thing that we are working on currently in the projects related to mental health is identifying and addressing some of the disparities in care that we see when it comes to both physical health and mental health. Compared to the general population, those with intellectual and developmental disability are 2 times more likely to have cardiovascular disease, asthma, arthritis, and other chronic health conditions. They're 3 or more times as likely to be hospitalized or visit the ER, which is very costly, and 5 times more likely to have diabetes and or severe dental health issues. And these all accumulate to mean that the lifespan for those with IDD is about 20 years shorter than the general population. And looking at mental health concerns specifically, if you remember on the previous slide, it was about 1 in 5 in the general population experience a mental health concern. Our most recent research shows that about 50%, 1 in 2 of every individual with IDD have a diagnosable mental health concern. So on average, individuals with intellectual and developmental disabilities are 2 to 3 times more likely to have a mental health concern than the average population. However, also like I mentioned before, a lot of those are undiagnosed, misdiagnosed, and potentially mistreated. If you are interested in looking into some of the research that tracks these health disparities that are experienced by people with intellectual and developmental disabilities, this H-card study, and I wish I could remember the acronym all the time. I do have the link in here, and I will share the slides. You'll be able to access that. It's one of the largest and longest longitudinal collections of health disparity data that we have among individuals with IDD. So about 66,000 adults in Ontario, Canada since 2010 This is really the first comprehensive and the most reliable picture that we've had as far as figuring out what those health disparities look like in physical and mental health care. This is a little bit of a picture of what that data, oh, thank you, Deanna, for putting that in the chat. This is a snapshot of what that data source looks like as far as where this is from. They have a collection of health data, social services data, and they have that collection of data on almost 20,000 individuals. They have data from both of those sources. So a very large data set, and for about a third of the data, they have data from both of those sources. It provides a really, really good picture. This is from the H-card data set. If you look at the legend, that is really small. The blue bar is percentage prevalence among people with disabilities. The orange is among people without disabilities. Down here on the far right, you have a psychiatric disorder, hypertension, asthma, diabetes, chronic obstructive pulmonary disease or COPD, and congestive heart failure. They are all, people with disabilities are far more likely to experience all of these. You'll see hypertension is the same across both groups. But you also notice that none of these are lower for people with disability. And one thing that always comes into play when we're talking about accessing healthcare, particularly mental health care, is cost and frequency of visits, being able to access a professional who you feel hears you and is able to address your concerns. Again, the blue bar is individuals with disabilities and the orange is without. All specialists, people with disabilities, see specialists at a higher rate than those without. If you look at the middle, that's the psychiatrist. It's a much, much greater rate for individuals with disabilities than those without. This graph is, for some reason, a little bit more poor quality, but this one shows hospitalizations. Again, people with developmental disabilities are far more likely to be hospitalized, spend time in the hospital, particularly as you see the age increase, that 55 to 64 age bracket. There's a massive disparity between how much time they're spending in the hospital. And finally, we take a look at medication use. And this is people with developmental disabilities. This one does not show the comparison. 40% of adults are prescribed medication. And medication by class, you'll notice the legend on this one is slightly different. The blue bar is medications that are non-psychotropic, and the orange bar is medications that are psychotropic. So in that study, 39% or about close to 40% of adults were dispensed antipsychotic medication, even though 1 in 3 of them didn't actually have a documented psychiatric diagnosis. So on one hand, you have them being prescribed antipsychotic medication, but there's no documented diagnosis. So why are they being prescribed these medications? Is one of the many, many questions that has arisen because of this data, but particularly relevant to our topic tonight. Generally, if someone is being prescribed an antipsychotic, you anticipate that there's a matching diagnosis that explains that prescription. This elaborates on that a little bit more. 20% of those who were dispensed antipsychotics were dispensed 2 or more at the same time. We're switching gears a little bit, keeping that in mind, how many disparities there are in healthcare access, how much more time people with developmental disabilities spend in the hospital. A lot of these were highlighted and exacerbated by COVID-19. My personal experience with this, before I was at the Institute for Disability Research, Policy, and Practice, I was managing residential habilitation services in Idaho. And I left that position shortly after COVID started, but I saw the very beginning of the chaos. It was really hard to get our participants into practitioners. It was really hard to schedule appointments. We had the staffing crisis come into play as well. So there was so much going on, and I could tell that our participants were really going to be affected. And over time, it became very obvious people with intellectual and developmental disabilities were more likely to experience a severe case. There was massive disruption to daily routine. There was, like I mentioned, the staffing crisis. There was a loss of informal and paid supports, and a lot of social isolation. A lot of the methods and resources that we had to promote community engagement and involvement were limited. And there was a concurrent rise in mental health concerns among the general population, but particularly for people with mental health, for people with intellectual and developmental disabilities, as well as their caregivers, because there was now an increased burden or need for care because those paid services and supports became less available. You may be familiar with the term diagnostic overshadowing. It's where potential symptoms of a mental health concern or mental illness are mistakenly attributed to an intellectual or developmental disability. And unfortunately, the result of that is that the mental health concern isn't diagnosed, it's not treated. It can also be misdiagnosed if there's conflation of symptoms between the two. Diagnostic issues are the most frequently reported barrier to serving people with intellectual and developmental disabilities who also have a co-occurring mental health concern. When you're providing diagnostic services for mental health concerns in individuals with intellectual and developmental disability, there's a lot to consider, and there's a lot of context that needs to be taken into play. So the way that we address this and suggest addressing it is through a more systems-based lens. A couple of the things that providers have mentioned when they struggle to accurately diagnose or identify a mental health concern is that it's not always clear when a problem with mood or thinking becomes serious enough to be a mental health concern. So, for example, sometimes a depressed mood is normal. When a significant change happens, there's a loss, a significant change in routine. But if that depressed mood continues for a prolonged period of time, it gets in the way of baseline behavior, that person may benefit from professional care, and it may be a diagnosable mental health concern. One of the best supports and sources of information that we have are family or friends or other natural supports who are able to recognize changes in baseline behavior or concerns that a person doesn't see in themselves. However, this is complicated in individuals with intellectual and developmental disability or atypical behavior, communication, or intelligence, because our diagnostic manuals and all of our trainings generally are designed around, quote, typically developing individuals. So we widen the picture a little bit and consider our context. A few things that are really important to consider in diagnosing mental health concerns are the wide variety of conditions that might be classified as a developmental disability and the diversity of the effects of those that can lead to an especially complex set of diagnostic considerations. And the reason this is important as family members and caregivers and natural supports is that oftentimes we interact with professionals who are very, very well intentioned but do not have the training to work with your family member or the individual who needs support. As a family member or caregiver, you can provide insight and suggestions that might help them steer this diagnostic process in the right direction. The goal being to approach it with a more systematic, holistic perspective that includes the individual and their opinions and their voice, as well as family members, caregivers, and others who are able to notice changes in behavior. Some mental health concerns, some symptoms can be related to or mimic a medical condition. For one example, depressive symptoms can relate to a thyroid condition. Therefore, a mental health diagnosis often begins with a full health evaluation, including a physical exam. That could be blood work, neurological tests, a lot of times checking for pain and discomfort. One of the things we run into in diagnosing mental health concerns, a lot of our evaluation tools in the mental health field rely on self-report and self-reflection, being able to identify that in yourself. They're also designed very much for typically developing individuals. There isn't much consideration thus far for neurotypical individuals or individuals with intellectual and developmental disability. There are a few steps we can walk through when we're conducting a mental health assessment or preparing. If you're going to accompany someone that you support or a family member for a mental health assessment, it's important to consider the referral source. So who made the referral? Are we referred to the right person? That's somewhere to start. Think about who made the referral and who you are referred to. What's different now from baseline behavior? What triggered this referral? And why now? So thinking about some of that context. And then presenting the problem and past history. As a care provider or family member, they're likely going to ask you what you've seen, how the behavior has changed. So thinking about how long has this been a concern? Is there a history of other mental health or behavioral treatment? This is the thing. Think about when you're approaching a mental health assessment or diagnostic process. Something else that's incredibly useful is preparing some information about personal and family health history. So anything from medication, substance abuse, psychotropic medications, specifically antipsychotics, they can have pretty severe side effects. And then any other medical conditions, especially things that are genetic, that might not have been taken into consideration yet. You mentioned hyperthyroidism earlier. That's something that can mimic, depending on whether it's hypo or hyper, can be anxiety or depression-like symptoms. Constipation, epilepsy, diabetes, GI issues, when you're talking about your gastrointestinal system, anything that can cause pain and discomfort. Medical conditions, unfortunately, like mental health concerns, are often underdiagnosed or misdiagnosed among individuals with intellectual and developmental disabilities. And a few other things to consider: the social and developmental history for the individual, developmental milestones, relevant school and work history, their current work and school status, if what that family dynamic and support system looks like. So whether you are a paid caregiver or your natural support, thinking about what their living situation looks like. Drug and alcohol history, if there is any, as well as any trauma or abuse history. That's something important to consider when we're diagnosing both physical and mental health concerns. And when it's appropriate, observation of nonverbal behaviors. This is another big conversation that's happening in the self-advocate community, is behavior as communication. When is a behavior serving a communication purpose, and when is a behavior just a function of being a human being? So something to consider as well.
Real quick, Rachel, I don't want to jinx it, but we have not lost a single participant. So everything is going super, super great. But
Okay.
just in case anybody does need to sign off, I just, you know what I mean? I just wanted to um throw it. I will put up the information for the Fall Family Festival in the chat. Sorry, I panicked earlier and didn't have it off the top of my head. So I'll put that in the chat. And I will also put the information. We'll contact the prize winner. It was, and I feel bad, I think it's Christine Hatton. Did I say that right? We'll be able to contact you with your registration information about your prize. But we're going to keep going. Your prize is 5 single-day passes to Discovery Gateway. Congratulations. So Rachel, again, keep going. We will check back in at like 8:50, literally. So we'll just let you keep going with your time.
Okay.
Thanks.
Awesome. Thank you. There is, if you are familiar with the DSM, the diagnostic manual, there is a version for people with intellectual and developmental disabilities specifically. This is something that you might find handy as a family member, a caregiver, or a direct support professional if you're just curious to know what those official criteria look like when a mental health professional is walking through this situation, because this is likely what they're going to refer to as well. Again, a lot of diagnostic tools are self-report, and that isn't necessarily the most effective way to do things when we're working with someone with an intellectual or developmental disability. One example, and this is a case study from our team. This is a true story based on a true story. A 22-year-old female with intellectual disability and significant communication deficits was brought to her primary care provider by her mother, who was concerned that she had been pulling her hair out. A preliminary assessment didn't reveal any immediately evident health issues. Nothing was terribly concerning. So they went home. A few weeks later, during a regularly scheduled dental exam, the dentist discovered a split upper molar and extracted the tooth. And a week later, the hair pulling had stopped. So this is just one snapshot of a scenario where a mother witnessed a behavior, was concerned that it was possibly a mental health concern or an indication of a change in baseline behavior. She did a wonderful thing to take them to the doctor to have a physical and exam. Unfortunately, it wasn't evident there. However, pursuing regularly scheduled care, fortunately, at this dental exam, the dentist was able to identify a source of pain and discomfort. And once that was addressed, the hair pulling stopped. There are definitely a long list of potential diagnostic challenges when we're talking about mental health concerns, especially when we're working with people with intellectual and developmental disabilities. It's important to think about, as I mentioned, the medications that they're taking. It's possible that medications are causing side effects, communication challenges. It can be difficult to understand how a person is feeling. Potentially atypical presentation of psychiatric disorders, because a lot of our diagnostic criteria is built around typical or normally, quote, developing individuals. We may just not have a good picture of what that looks like for people with intellectual and developmental disabilities. And it's just not well integrated into our diagnostic criteria. Probably the biggest issue and the hardest to address is that we are trying to navigate probably 2 or 3 systems at a time when we're working with someone who has co-occurring mental health concerns and intellectual and developmental disability. You're likely trying to navigate the medical system, a primary care provider, public health, the intellectual and developmental disability system, if they're receiving disability services or supported living services in any way, as well as the mental health system. This is how our system is designed. We have 3 separate entities. Now we do have, there's some effort to coordinate and cross collaborate, but there's still a lot of siloing going on. We hear that from a lot of self-advocates and parents and caregivers, is that it's still incredibly challenging to navigate. So that in itself is a massive barrier. The philosophy, funding, and approach behind each system is different, and there's sometimes issues of ownership, or whose responsibility is it to address the mental health of an individual with IDD? Should it be funneled through disability services? Should it be primarily through mental health? And just because an individual qualifies for disability services doesn't mean that they will qualify for mental health services and supports. Those requirements are different in a lot of scenarios, so it can be challenging to get someone the disability services they need as well as the mental health services they need. They may qualify for one or the other and not both, and that may not be adequate for helping them achieve independence and community integration. One reason that we have ended up this way systemically is that there's been primarily a medical view, a medical model used to view disability, which is that there is a defect or impairment and it can be diagnosed, and there's some sort of treatment, and then the individual is cured. So in this medical perspective, it's a problem with the individual that needs to be fixed, and it's the individual's responsibility. When we compare the disability and mental health services, there are some differences in perspectives on how services are provided and how it's approached. Disability services system is more rehabilitation, self-determination. We use terminology participants or consumers. There's care coordination, working with multiple groups. And there's a long-term or lifetime approach. There's typically an expectation that some sort of support will be needed long-term. In the mental health system, it's more about rehabilitation and recovery. It's this anticipation that something will be fixed. It's more of a short-term approach. There's case management, very small sphere generally, and we talk about our clients or patients. Ideally, we need to cultivate some shared responsibility. Unfortunately, I wish I had a magic wand. I wish I could make everything perfect overnight. Systemic issues can't be fixed that way, and they can't necessarily even be addressed by the individuals who are working in those systems. However, by being aware and being proactive about coordinating care across these systems, that's how we can best meet the needs of individuals with intellectual and developmental disabilities in our current situation. Although there's very little research or randomized controlled trials, which are the gold standard for establishing evidence-based practice for mental health concerns among individuals with intellectual developmental disability, there is well-established research and there is evidence that demonstrates that an integrated care model or collaborative care is extremely beneficial for this population. And when I jumped on earlier, I believe it was the tail end of a discussion about the Uni Home program. It's an excellent model. That is something that I would love to see replicated, but it does require a lot of resources. It's geographically limited because of that coordination. So there is a wonderful opportunity and approach, but it is challenging to implement in a lot of ways. This integrated care model, and if you're familiar with Uni Home, you may know some of this or be familiar with graphics like these. There's a lot that goes into that. And the goal is ultimately the individual is able to actively participate in the life that they want to live. I like to point that out because a lot of times historically we talk about being productive in a way that they're contributing to society, or how we see them as productive or how we want them to be. It's about conformity. This integrated care model places the individual's influence and their goals in the center, and their supports help them reach those. Ideally, that integrates mental health, physical health, our education, disability services, and then we have our paid and unpaid supports and community supports as well that collaborate to help them achieve those goals. This integrated care model is impossible without informed advocates who are able to provide essential information and to make sure that those healthcare needs are met. So we could not do this without the family members and caregivers who spend so much time putting effort into accessing care for these individuals. As I mentioned, there's not a lot of randomized controlled trial research, but there are definitely approaches that are evidence-based who have shown to be beneficial, particularly for individuals with intellectual and developmental disability. You'll see acceptance and commitment therapy is a personal favorite. That's when I use principles of that for myself. Applied behavior analysis is at the top of that list. I will note that this is another point of discussion among self-advocate groups. There are some who don't appreciate applied behavior analysis, and there's some conversation around how it should be used and when it should be used and when it's useful. There's mindfulness, group work, family-based interventions can be helpful. And at the bottom, we've got medication with the caveat that if and when it is necessary, because based on the data that we've seen, medication tends to be overprescribed for individuals with intellectual and developmental disabilities. These are things that you are probably all very familiar with as caregivers and family members and supports. Some of the most important things we can do when we want to support the mental health of individuals with intellectual and developmental disabilities are to recognize and also help combat the myth that people with intellectual and developmental disabilities don't experience mental health concerns and don't experience the same emotions as everybody else. They absolutely do, and they have the right to mental health care just as much as the general population. As a professional, it's important to consider the possibility of an underlying mental health concern. We can see from the most recent research that prevalence is as high as 50%. 1 in 2 individuals with intellectual and developmental disabilities also have an underlying mental health concern. Social support is important for everyone. This was a major challenge during COVID-19. Having robust and reliable social support is a foundational element of mental health for everyone. It's just as important for individuals with intellectual and developmental disabilities. That natural support network and that paid support network is extremely important. And also acknowledge and promote the idea that individuals with intellectual and developmental disabilities may experience any mental health concern. And there are lots of supports and strategies that can work and provide relief, such as counseling and therapy, meditation, medication as appropriate, like we've looked at in the previous slide, behavior modification, some of that applied behavioral analysis when it's appropriate, when it's deemed the correct scenario. There are a lot of things we can do. There are definitely, I've talked to providers who believe that individuals with intellectual and developmental disabilities can't benefit from therapy or won't benefit from therapy. We have evidence to show that they do, they can and they do. So that was a lot of information for me, regurgitated very quickly. What do we want to walk away with? What do I hope that you take away from this presentation? One thing to consider is that the amount and quality of research among individuals with intellectual and developmental disabilities is insufficient to present really clear clinical or treatment guidelines, which is why we don't have them. We do have the diagnostic manual for intellectual disability, but that has its limitations as well. This is something that we are working on. This is something that at the Institute, we hope to contribute to this evidence base and continue pushing for further research and support in this area. The information we do have, unfortunately, is not being disseminated appropriately or widely enough in training programs into direct care staff. For our Utah MHIDD landscape analysis, something we learned from mental health providers is that they felt their education was not sufficient enough to provide services for individuals with intellectual and developmental disabilities. So we are actively working to address that through webinars, trainings. We are currently designing a mental health literacy training for direct support professionals. In spite of the lack of research and the lack of training that we're seeing, the basic principles of positive psychology, social support, and therapy are effective for all populations. When we're working with individuals with intellectual and developmental disabilities, they might require a more individualized approach. That does not mean that they aren't effective. What we do know, ultimately, is that coordinated cross-system intentional care is the most effective method for diagnosis, treatment, and ongoing support of mental health concerns among individuals with intellectual and developmental disabilities. We will have, hopefully, some training opportunities for family members and caregivers. Our MHIDD training grant is primarily focused on paraprofessionals, direct support professionals, especially in residential settings, but we also hope to provide resources for family members and caregivers in the future. If you want to be added to our contact list for those upcoming trainings or resources that we provide, please drop your name and email in the chat and I'll get you added to our list. I'll share these slides so you'll have these resources. You guys talked about the Union Home Clinic earlier. We have, if you do know professionals who are interested in training, we have a direct support professional course that actually just started on Tuesday, and that's on mental health among individuals with intellectual and developmental disabilities. We also have a case manager care coordinator training that starts next month in October. And these are free, I should note. They typically cost $150, but we have a contract with the center that provides these and we will cover the cost of your registration. If you are a case manager, care coordinator, if you know somebody that would be interested, please feel free to share this with them. We don't have time to dive into the sources of distress survey, but this is a tool that a lot of caregivers have found helpful. Typically, it's completed by a caregiver on behalf of an individual with a disability. It's based on what you've observed and what's been reported to you. And then we also have a previous project. It sounds really similar to our current one, MHDD instead of MHIDD. This is a national training center rather than just Utah. And we have a lot of products that are on there that people have found useful, some webinars, podcasts. We have a digital storytelling series where people talk about their experiences. There's a lot there if you're interested. Ooh, okay. I made it through all of my slides. I know that
You're
was a lot.
amazing. That was awesome.
Probably talking way too fast, but we're here. We made it to the end. If you guys do want to hang out for a minute and ask questions, I'm happy to answer as best as I can. I see I've got a few names in the chat. I'll make sure I get you guys added to our list.
And again, so on behalf of the Family Links Committee, though, we really do. We thank you so much for this really informative session and all of the content that it provided. We couldn't have done it without you. So thank you so much.